Uh, Thank you very much for this presentation, for the invitation. I will try to be as much clear as possible because there are so many points that we can afterwards discuss after my presentation regarding the definition of what is quiescent choroidal neovascularization or macular neovascularization and what is just subclinical, non-exudative macular neovascularization. I will discuss this during this presentation. So these are my disclosure. Well, this is the definition of, let's say, macular neovascularization or choroidal neovascularization. Actually, we had a consensus recently, and the paper is on the point of being submitted. The definition of choroidal neovascularization is no more actual, as we know that the neovascularization may even develop in the context of AMD from the retina, like a type 3 neovascularization. So the consensus agreed to rename choroidal neovascularization as macular neovascularization. So you will see much more this term during my presentation, so macular neovascularization rather than choroidal neovascularization. And the type 1 is the one that develops in the sub-RPE, so just above the Brooks membrane, and it's also known as occult neovascularization. This is because it's not visible on fluorescein angiography. And this is the way type 1 neovascularization develops. So you can see from the choriocapillaries breaking the Brooks membrane and then growing beneath the RPE with exudation. So the typical characteristic for type 1 neovascularization is subretinal and some intraretinal exudation. But actually, more than 20 years ago, the group of Larry Iannuzzi realized that in the fellow eye, as you can see from this slide, of patients with typical active exudative type 1 neovascularization, well, it was already possible to detect a large plaque on ICG. So the presence of what could be considered inactive subclinical type 1 neovascularization. I must admit that at that time there was no OCT, so there was no structural OCT demonstrating the complete absence of exudation. You know that sometimes it is somehow difficult to detect some minimal exudation on even on a stereo fundus examination or fundus photograph, as well as minimal leakage on FA. So based simply on fundus examination and FA, at that time, this group decided to state that this neovascularization well visible on ICG, and well, they were not exudative. Let's say more or less 15 later, our group, and I was the first author for this paper, introduced the term quiescent macular neovascularization, at that time quiescent choroidal neovascularization. Type 1, treatment-naive quiescent neovascularization. And this is the picture, the typical picture of a quiescent type 1, treatment-naive type 1 neovascularization. So you can see that there is no clear evidence for type 1 neovascularization on FA, as it is an occult neovascularization, while we can nicely see this late plaque on ICG. And well, this type of neovascularization was characterized on structural OCT, cross-sectional structural OCT, by absence of exudation in the retina, in the subretinal space. But at the same time, it was well visible, this flat, irregular RPE elevation with some highly hyperreflective lesion stuck on the back surface of the RPE. And the definition of a quiescent CNV, or macular neovascularization, we also stated that it was necessary it was needed to have at least 6-month follow-up without demonstration of exudation on a structural CT. So a minimum of 2 consecutive examination after a minimum of 6 months in order to be defined quiescent CNV. But despite this minimum 6-month follow-up, we also realized that while they were clinically quiescent because of absence of any kind of exudation, indeed they were biologically active because, as you can see here, there was some growth of this plaque on ICG. So growth of the CNV in absence of exudation. Then, in this editorial in Retina, we also realized that not only large plaque on ICG could be defined as quiescent, but also small macular neovascularization mimicking drusen or a small PED, pigment epithelium detachment, could be quiescent. You can see here this that looks like a drusen on structural CT, and if you look at fundus, also they look like a drusen. They may grow over time slightly, so 2 years apart, in absence of exudation. Well, this is already neovascularization as demonstrated by ICG and also as demonstrated by OCTA. So also very little, very small neovascularization mimicking drusen may be present in eyes of patients without symptoms, in eyes without any kind of exudation. This is what we define vascularized drusen. Well, a couple of years later, we also demonstrated that OCTA for large typical quiescent type 1 neovascularization could be effective in demonstrating the presence of the CNV, of the macular neovascularization, in absence of exudation. So you don't strictly need to do ICG in order to detect a quiescent macular neovascularization. But at the same time, in this paper, we realized that not all quiescent neovascularization could be detected on OCTA. So this is a typical example where you can nicely see this plaque, late plaque on ICG, but at the same time, this smooth, irregular RP elevation, all the typical characteristics of a quiescent CNV, but at the same time, when you look at the 2 different OCTA, well, you cannot detect any abnormal flow in the choroid. So probably this is related to a very low flow in this quiescent CNV. That could be also responsible for the absence of exudation of activity of the disease. So based on our results, you can have the chance to detect quiescent CNV without ICG in a more or less 80% of eyes. So there is still 20% of eyes in which if you do just OCTA, you cannot find any changes. But if you do ICG, you can nicely see the presence of type 1 neovascularization. So this means that ICG is still the gold standard to make the proper diagnosis of quiescent CNV. And we also looked in this other paper at the growth on OCTA of quiescent CNV and also the rate of activation. As you can see here, only 7% of the included eyes in the study showed some exudation over a year follow-up. And this is the prevalence in the overall AMD. So if you look 100 cases of AMD with just drusen, you may have the chance to detect at least 1 case of quiescent CNV or vascularized drusen. In the same period, the Phil-Rosenfeld group published these 2 studies showing more or less the same feature that we did in our papers on quiescent CNV. So this irregular RP elevation with good visualization of the microneovascularization and OCTA. But at the same time, as you can see here, the rate of activation for the non-exudative type 1 treatment-naive macroneovascularization was 3-fold more than what we reported in our study. In our study, 7%, here is 21%. So what makes this difference between our series and the series by Phil Rosenfeld? One of the main points in this paper, in this description by Phil Rosenfeld, was that there was no minimum follow-up. So there was no minimum 6 months in order to define a non-active CNV. So quiescent means that you have to watchfully see the patient for a minimum of 6 months in order to state that they are quiescent, so they are inactive. While this is just, let's say, a kind of by chance detection of early type 1 neovascularization that is still going to develop exudation. This is why, this is our hypothesis, and this is also the reason why we try to better understand if there are differences between simple inactive, non-exudative type 1 neovascularization and real quiescent neovascularization. So we studied a group of eyes with quiescent or subclinical CNV over a year follow-up. We put together 3 different groups, and this in order to have a large cohort of eyes in order to get a statistical power. And of course, we looked at multimodal imaging, focusing on OCTA. And we were able to differentiate 3 different subtypes of quiescent or in subclinical neovascularization. One that is the real quiescent neovascularization, the one that is never showing exudative changes over time. The other one is the group that is very close to what was described by Phil Rosenfeld group, that is the group showing exudation before 6 months. So those inactive, those subclinical type 1 macroneovascularization that could not be defined as quiescent, so before exudation, before the minimum 6 months for the definition, but also those that were showing exudation, but after 6 months. So could be defined as quiescent, but that are showing exudation at a later time. Let's have a look at the results. So these are the overall results. In group 1, we had the largest number of eyes included, and these are the real quiescent CNV, the real type 1 treatment-naive neovascularization that could be detected, but that never develop exudation. Let's have a look at the clinical picture. This is the way this quiescent neovascularization are appearing could be detected on OCTA, and this is a 1-year follow-up. So it seems that there is no much change in the sites, and indeed the rate of growth is less than 1% per month, so very little growth over time. This is group 2, so the group that is showing exudation before than 6 months, so cannot be defined as quiescent, and you can nicely see how over 5 months, this is the time of detection, and this is after 5 months, there is a dramatic growth of this neovascularization, and this is the time when exudation was detected. Minimal exudation, but exudation was detected. When you look at the growth, the rate of growth, this is close to 20-fold more than a typical quiescent neovascularization. So it's around 13% per month, a huge growth. And this is a mean evaluation. Another important aspect in those eyes that are developing exudation, a kind of early exudation, but that at the beginning are non-exudative, is that the number of injections during the first year of treatment after developing exudation is very close to what we have in typical exudative type 1 neovascularization. So we need around 6 injections during the first year of treatment. And the rate of growth during treatment is around 6%. So despite continuous injections, so despite a normal PRN approach in this patient, we can see a continuous growth of this macular neovascularization. And here is the way this neovascularization is growing and showing a continuous exudation. Okay? Then we have group 3. Group 3 probably is in between. Is in between because, as you can see here, the neovascularization is not much growing over time. The rate of growth is more or less twofolds the one of typical quiescent. And what is even more interesting to note in this patient is that rate of growth during treatment, actually there's no growth during treatment. So if we do treatment, anti-VEGF injection in this kind of eyes that were real quiescent, but at a certain point, in this case after 22 months, are developing exudation. And well, when you treat these eyes, you can detect no growth in CNV. Probably is much more effective anti-VEGF, and you also need many less injections during the first year. So half the number of injections needed for a simple non-exudative CNV. Okay? And this is, you can see, there's no growth, and this is minimal exudation, so are really different than group 2. Another striking point is this. So when you look at group 2, and again, group 2 is the one that is showing exudation early, before 6 months. Well, the perfusion density, the packing of vessels inside the CNV is significantly higher as compared to quiescent in group 1 and group 3. Okay? I show you an example. So this is the packing of vessel. You can see these are looking really arterialized vessel. There is little connection between vessels. There are no fringe of new vessels around the macular neovascularization over time. So it's really something that is a kind of mature new vessel. And this is the way we analyzed. So you can see there is very little packing of vessel and no major changes over time. Well, when we look at group 2, so the one that is showing exudation early, there is the vessels are highly packing. There is a high packing of vessel. Perfusion density is much more, and also during growth. So this is a kind of demonstration that these are not mature vessels. This is why they are showing exudation early, and this is why they also need many injections during the first year of treatment. Okay, and the group 3 is more or less the same as group 1, so a real quiescent with a small packing of vessels, and this is also the reason why you don't need many injections during the first year of treatment. So this is my summary. It seems that group 2 neovascularization that at the beginning are not exudative, but that are showing exudation before 6 months, are those that are probably just detected by chance before development of exudation. And thanks to OCTA, we can somehow predict the chance of developing exudation and also adapt our rate of follow-up in these patients. You know, treatment-naive quiescent neovascularization are not needing treatments, because they are there, probably because they are giving, they are nourishing the outer retina, so they are doing a good job. And this is also a demonstration by this mature appearance of the new vessels and by the, this kind of arterialized appearance. And it was also demonstrated by histology that indeed we do have early neovascularization already inside the choriocapillaries without breaking the Brooks membrane, and that are there because they are stimulated by hypoxia and they are trying to supply somehow to this hypoxia. So it seems that there is a difference between subclinical type 1 neovascularization in treatment-naive eyes versus quiescent treatment-naive type 1 neovascularization. This is what Gas already described as the initial step in the evolution of typical type 1 neovascularization, that at the beginning is not exudative and then develops exudation in a certain time. At the same time, we have quiescent that are there, are arterialized, they are trying to nourish the outer retina, they are doing a good job, they are more arterialized, and they have very little chance to develop exudation, at least in short term. And this was already suggested by Bailey-Freund group in treated eyes, and by our group in this publication in the American Journal of a couple of years ago. So, take-home messages. You can use OCTA to detect a quiescent or a subclinical type 1 neovascularization, but unfortunately not in all cases. There is still more or less 20% of cases in which you should rely on ICG if you want to make the proper diagnosis of drusen, let's say, or drusenoid PED versus a subclinical quiescent type 1 neovascularization. If you look at the OCTA characteristics and the growth over time, and the packing of vessels inside the CNV, you can probably predict the chance to develop exudation, and so adapt your follow-up regimen. Late or no exudation in the context of subclinical quiescent type 1 macular neovascularization is something that is doing a good job for the outer retina. It's something that is continuously nourishing the outer retina, should not be treated, and may preserve development of atrophy that is the natural history of age-related macular degeneration. I wish to thank you for the attention, and my co-workers. Thank you very much.